Hello, good evening. Thank you all for joining us. I'm going to start by giving a brief overview of Ehlers-Danlos syndrome and hypermobility spectrum disorder. Just so you know a little bit about me, I'm a physiatrist with interventional pain fellowship training, and I'm also board certified in headache medicine. So looking at EDS, the first things we have to consider are the definitions. With Ehlers-Danlos syndrome, we know there are multiple types. The most common type is hypermobile EDS. Most of you may be familiar with that, also known as type 3. The important thing about hypermobile EDS is that there is no known genetic source. So if you go for genetic testing because you suspect you have EDS, don't be surprised if they tell you there's no test, genetic test anyway. There are genetic tests for other subtypes of EDS, like classical or like vascular, and we'll speak about some of the differences in those because there is a lot of overlap between the subtypes of EDS. I put a link at the bottom where there's a nice PDF overview of these subtypes. If you are interested in reading more about it, that's very easily accessible. So looking at the most common types of EDS, hypermobile EDS, there's about 1 in every 3,000 to 5,000 individuals. So it is fairly common as far as conditions go. We don't know any of the genes or proteins. It does seem to be autosomal dominant inherited, meaning you only need one affected parent to get it. And the core symptoms are generalized joint hypermobility, joint instability, and chronic pain. Classic EDS has a lot of these same features. It's less common. There are genes that are known, and it can affect type 5 or type 1 collagen. The biggest difference is skin fragility. So it's much easier to fracture skin. So skin over tight areas like the foreheads or the front of the shins can crack and break easily. It's also difficult to heal after surgery, and you may also have more saggy, stretchy skin than you would with typical hypermobile EDS. And again, you can have some of these symptoms with typical hypermobile EDS and not have the genes of classical EDS. It's just a range of the spectrum. Vascular EDS is where there's vascular fragility, meaning the arteries can rupture and you can have severe life-threatening bleeding. This can occur in the aorta, in the vertebral artery, a lot of different areas. The other interesting thing about vascular EDS is that it also affects the organs, and it's very easy for the organs to rupture. You may have heard of pneumothorax, which is the lung spontaneously rupturing. And of course, this can happen with classical EDS, but it's more a hallmark of vascular EDS. And of course, you can have spontaneous spleen fractures or liver bleeding, other things like that. Looking at the EDS spectrum, this is really just looking at hypermobile EDS and all of the symptoms that go along with it. I borrowed this from the Ehlers-Danlos Society because they have a lot of great educational material on their website. So when you're looking at these core symptoms, we're thinking about joint instability, mast cell activation syndrome, which happens commonly with hypermobile EDS, pain, fatigue, GI issues, dysautonomia, headaches, and anxiety, other neuropsychiatric side effects. We'll get into that in a bit. This is a better Venn diagram sort of showing the overlap. They've got classical EDS here over on the side, vascular EDS, and then the kyphoscoliotic EDS at the bottom. So you see in the middle, there's easy bruising, joint hypermobility, and then there are some other more specific issues that happen more commonly within each subtype of EDS. How do we diagnose hypermobile EDS? Well, it's history and physical exam. So if you go see a geneticist for hypermobile EDS, they're probably going to whip out a form similar to this. They're going to check the Baton score, which is these 5 maneuvers looking for hypermobility, and then you get a score based on that. There's all of these questions that you have to go through and certain criteria that you have to meet. And this was developed by a consensus of professionals. This is not evidence-based. It's purely professional opinion. And it will probably change in 10 or 15 years or whenever this consensus group meets again. The most interesting part about this is at the bottom, which I'll get a little deeper in that in a second. When we talk about hypermobility spectrum disorder, what's the difference in hypermobile EDS and hypermobility spectrum disorder? The only difference is that you meet the consensus criteria. So they are otherwise exactly the same. And this is important because 3.2 on that form that I showed you before says exclusion of other heritable and acquired connective tissue disorders, including autoimmune rheumatologic conditions. So I don't know how many of you have or know people with hypermobile EDS, but coincidentally, there seems to be quite a high confluence of autoimmune processes. And it can be quite confusing as you dig into it because mast cell activation syndrome, which is allowed, it's not considered one of these autoimmune that would exclude you from having hypermobile EDS, but it does often present with other autoimmune-like processes and can be quite confusing. So if you do have a primary autoimmune condition like lupus, rheumatoid arthritis, psoriatic arthritis, Sjogren's, any of these things, then you actually have to go back and meet a lot more additional features to satisfy the diagnostic criteria for hypermobile EDS. And most specifically, your parents have to have it. All right, let's dig into some of the associated conditions with hypermobile EDS and hypermobility spectrum disorder, because this is often how we end up diagnosing hypermobility syndromes, because patients don't come in complaining of being hypermobile necessarily unless their shoulder is falling out. They generally come in complaining of some array of symptoms that has been misdiagnosed as fibromyalgia, or it's all in their head, or something along those lines. So we're looking at headache. People in the normal population, looking at migraine specifically, people with hypermobility, 30% have migraine, as opposed to the normal population where it's 6% of men and 18% of women. So headache is much more common with hypermobility. Neuropsychiatric side effects, so ADD, ADHD, OCD-like symptomatology, which Dr. Barbieri may speak about a bit more. Craniocervical instability, and this speaks to a whole subset of symptoms that occur when the head is not securely fastened to the neck. We know the head weighs about 25 pounds. The neck is relatively small. The ligaments responsible for holding this juncture together need to be sufficient. If they are not, the head will start to slide onto its post on the neck. And when that happens, a whole variety of other symptoms occur. You can have restriction in cerebrospinal fluid outflow from the brain. You can have compression of the jugular veins. You can have tension on the nerves that exit the brain, like the sympathetic plexus, the vagus nerve, the glossopharyngeal nerve, and these can each present with their own symptoms without any other symptoms of CCI along with it. So diagnosing CCI and looking at the bigger picture is important. There can be dental issues or TMJ dysfunction. Thoracic outlet syndrome, which is where the nerves that come out of the neck course between many muscles en route to the arm. So with thoracic outlet syndrome, there is compression of veins, arteries, and or nerves as they exit the neck and exit the thorax, which can be due to hypermobility. Dysautonomia. The dysautonomia means that your autonomic nervous system is not functioning appropriately. What does the autonomic nervous system do? It balances all of the body's automatic functions. So if you think of your pulse, your blood pressure, sweating, digestion, normal movement of the gut, even your fear and anxiety responses, your reflexes can even be modulated this way. So the dysautonomia can be affected because if there is some craniocervical instability, if there's any stress or stretch on the vagus nerve or the sympathetic chain, it will affect how all of these things function. And separately, if there is too much stretch in the ligaments that hold the bowels in place, too much stretch in the tissues of the gut, or any of the other organs for that matter, it will affect the reflexes and the dynamics between them. So what does dysautonomia present like, or how can it present? If you're familiar with POTS or positional orthostatic tachycardic syndrome, if you stand up and get dizzy, or if spontaneously you feel like the heart is just beating really fast, that can be a type of hyperadrenergic POTS. Adrenal insufficiency, which when the adrenal organs, which are responsible for producing cortisol and aldosterone, those are more commonly affected in EDS than the normal population. You can have insufficient hormone production so that you actually have more POTS from that. And you also get volume distension because gravity and stretch pulls all the blood as close to your feet as possible, and the blood vessels are stretchy so they can accommodate them. Gastroparesis means that the stomach is not moving. You need the vagus nerve for the stomach to empty, and if the sympathetic nerves are hyperactive, then the stomach will also not empty and the bowels will slow down. So this will keep the stomach from emptying. This can cause nausea. It can cause acid reflux to come back up the other direction. It can cause the small intestine bacterial overgrowth because things aren't moving along. The bacteria just build up. And of course, it can cause constipation as well. And these things can all co-occur. Usually when we think of hypermobility and EDS, we think of joint subluxations and dislocations. That's almost one of the hallmark symptoms. But you do not have to have these to have hypermobile EDS or hypermobility spectrum disorder. You can have a lot of these other things going on, and the joints might be loose, but they may not actually spontaneously sublux. You can still be more prone to sprains and injuries, of course. But subluxation of the joint, which is where the joint is sagging or there's hypermobility of the joint, dislocation where it's actually properly displaced. Anytime either of these happens, there's also injury to the surrounding structures. So if you think of the shoulder dislocating, the shoulder cannot dislocate without injuring the labrum. Same thing with the hip. Even a subluxation will often pull and tear at the labrum. And the muscles that are responsible for holding the joint in place, the rotator cuff muscles, are also overused. There's often tendinopathy, and you can even get tendon tears in the rotator cuff because those muscles are often working overtime just to try and hold the joint together because the ligaments that are supposed to be doing that job are too stretchy. Gravity compliant posture. This is the polite way of saying bad posture. If you think of typical upper body sagging, hyperextended neck, bad posture, that's generally how gravity will pull a person down if the ligaments don't sustain the forces that gravity puts on them. And this will contribute to some of these other issues like the TMJ dysfunction because head and neck positioning affects jaw function. It will play into thoracic outlet. It will play into blood flow going back into the brain. There's a lot of trickle-down effects from this. Organ prolapse. So this is where we think about bladder, rectocele, even stomach with hiatal hernias. This can happen in a lot of different locations. Don't always know that they happen until we take a look. Sometimes we find it just by accident. Other times patients come in with that specific complaint and we have to question why this is happening, and that leads us back to a diagnosis of EDS. Vascular occlusions. Vascular occlusions will happen for a couple of different reasons. One reason, especially with venous occlusion, it's just that the veins do not have enough intrinsic strength to stay open and they will collapse. They'll just spontaneously collapse. If there's enough blood flow, yes, they can open back up, but sometimes it takes a good amount of blood flow, and sometimes the resistance downstream from that blood flow is so low because the blood vessels are so compliant that the blood pressure doesn't really build up to allow the vein to open up so that blood can return. So it just pools and stays distal to the heart. This happens more with pelvic congestion syndrome in the iliacs in the lower part of the body. In the upper part of the body, the jugular vein can be compressed because it's stretched or tented over the C1 transverse process or a styloid process, or it can just spontaneously happen there as well. MALS and SMAS, median arcuate ligament syndrome and superior mesenteric artery syndrome, are two specific diagnoses that happen more often in hypermobility. And in this situation, it's blood flow affecting the gut. And because they're sagging and stretching of the ligaments that hold things in place, the arteries can become occluded. With arterial occlusion, you actually lose blood flow and oxygen to an area, which causes substantial pain. Typically, it causes abdominal pain and nausea. And nausea might even be the prevailing symptoms of this. And then, of course, pelvic congestion syndrome, which is where blood just pools in the pelvis. And May-Thurner is when there's a valve disorder and that causes pelvic congestion. Pelvic pain dysfunction, we know about that. We mentioned mast cell activation syndrome. There's a number of autoimmune conditions that seem to be more prevalent in hypermobility syndromes, and then poor healing. Other considerations, there's a lot of other conditions that present with things that seem like hypermobility or have hypermobility or share a lot of the same symptoms. So we don't just jump to this diagnosis, even though it is very common. We want to make sure there's not something more ominous in play. And what is our clinical approach? Generally, we want to identify the primary conditions. Is there hypermobility? Is there craniocervical instability? Is there migraine? Because if there's migraine, it's going to sensitize everything. Is there PTSD? Because this plays into the sympathetic pathways, and dysautonomia and PTSD follow the same pathways. Are there other specific injuries or primary pain sources, like endometriosis? Anything else that's going to cause pain or sensitize the nervous system, we need to identify, we need to know about. If there's any structural instability, if there was a sprain or a prior injury or a fracture or anything that's affecting the mechanics that's not hypermobility or that may have been worse because of hypermobility, we want to understand all of that and put it all in context together. Then we want to look for secondary conditions. And this is important because it's often the secondary condition that brings the patient in. They may come in with myofascial pain or dystonia, which is involuntary muscle contractions. We see a lot of pelvic dystonia from pelvic floor dysfunction. They may come in with a shoulder subluxation or TMJ dysfunction or a peripheral nerve entrapment. It's important to recognize if that is not a primary process, because if we treat the secondary process without recognizing the primary processes, the patient's not going to get very far. They're just going to keep having the same issue over and over. So we want to understand the how, what, and why behind the pain that brings the patient in. Once we get an understanding of that, we discuss it. I map it out for the patient, and there's usually a cascade, one thing leading to another, that helps us understand the constellation of symptoms that are going on. And once we have that, we kind of want to choose where we start to tackle this. And it's almost like there can be layers of patina or a snowball effect of all these things that have built up over time, because it's not usually something that just happens instantly. It's usually years and years of things building up until they get to a point where it's no longer tolerable. That's when they seek care. So we want to establish priorities and goals, like what's the most important thing of all of these things going on, what causes the greatest amount of dysfunction. We want to track that back to a presumed root cause and try to treat that spot, treat that area. So when we look at treatment categories, we think of these buckets of treatments. We look at medications, and medications generally don't fix things, but they can make them better temporarily. And if we find a medication that does something, that has some effect, that gives us more information about what's going on with the body, depending on which neurotransmitters are in play or whether there's inflammation or not inflammation. If we think there might be mast cell activation, we give a mast cell drug, we see if that changes anything. It really helps us understand what's doing what. And that's important when we put together the full treatment plan. So there is a little bit of trying to understand what's going on with the body. There are physical modalities, which we think about physical therapy, which is essential for proprioceptive training, strength training, balance training, all of these things to learn to re-coordinate the muscles, recognizing the end range of the joints. We also think about chiropractics, which do have a role in hypermobility syndromes. We can talk about this later because it's quite nuanced and you really want to know what you're getting into. But there are distinct roles for chiropractors with hypermobility, acupuncture, other heating, stretching, cold laser. There's a lot of other physical modalities that people use that are worth discussing because some can be helpful, some can be harmful. We really want to question what we're doing, why we're doing it, what we're anticipating this will accomplish. And then whatever happens, we learn from that and we incorporate it into our bigger understanding of what's going on. When we get to procedures, that's where we're looking to diagnostically confirm something. And I say this because it's quite broad and it is quite vague. There are a lot of things we can test diagnostically. If we think a joint is a source of pain, we can put local anesthetic in the joint to turn pain off and then confirm if that's a source of pain or not. Just putting local anesthetic on a structure won't confirm if hypermobility is the problem. If we want to test for hypermobility, imaging is generally not great. Some situations we can, but it's not always reliable. For the hip, for example, we may just put fluid in the hip and see how much fluid is accommodated by the joint. If we can put more than a certain amount of fluid in the hip, for example, we know that there's hypermobility there because otherwise it wouldn't accommodate that amount of fluid. And then if the patient gets up and walks around and feels more stable afterwards because we've given pseudo-stability by filling the joint with fluid, that is additional confirmation that hypermobility was present and that hypermobility was contributing to dysfunction of that structure. One of my favorite locations for this specific thing is at C1, C2. So if we are diagnosing craniocervical instability and we see on imaging that C1-2 is hypermobile, I can go into the joint with a very teeny tiny needle and place fluid. And the joint is only supposed to hold 0.3 mLs of fluid. Generally, with hypermobile patients, I can put a cc and a half into the joint. That by itself proves that they're hypermobile. And then immediately afterwards, we have them sit up and see how they feel. And whatever feels better from that joint being full and distended is directly related to what the hypermobility of that joint was causing as a problem. So this is the diagnostic process for hypermobility with pain, because a joint may cause problems without itself being painful. And this is where things get really confusing. When it comes to pelvic pain, for example, it's quite common for sacroiliac joint hypermobility or hip joint hypermobility to cause pelvic floor dysfunction because all of the pelvic muscles will react to stabilize the pelvis, and there's no primary pain in the SI joint or the hip. How do we figure this out? We examine. If we feel hypermobility on exam, we put fluid in the joint. If that allows the pelvic muscles to relax, then that's proof of concept that it's just reacting to the instability of the joint. Then we proceed with regenerative medicine options, which are meant to tighten or strengthen the supporting structures of the joint, which is a longer-term solution. Now, of course, not everybody responds to every treatment, but these are what we have available. And generally, we will start with dextrose prolotherapy, where we inject sugar. The sugar chemically irritates the ligaments, which makes the collagen proliferate. It makes the ligaments become stronger, and it tightens the joint. If they do not respond to prolotherapy, we will generally escalate to platelet-rich plasma, PRP. That's where we draw your blood, we spin it down, we inject the platelets. The platelets themselves produce a healing response, which can also stimulate proliferation of the collagen and strengthen the structures. And between these two things and physical therapy, we can generally treat a hypermobile joint and make it more functional and less painful. Finally, knowing that there are neuropsychiatric side effects to hypermobility and knowing that there's widespread effects of hypermobility and pain on someone's life, the role of pain psychology cannot be overlooked. So even if it's as simple as strategizing care, making goals, pain psychology can be very helpful. Dr. Barbieri will talk more about that. And finally, it's important to know that everyone's response is different. Everyone is individual, and as much as it would be nice to have cookie cutter medicine like we have for blood pressure or diabetes, we do not have that for pain, at least not yet. So there is a little bit of an iterative process where we try something, we see what happens, we see how the body responds, we incorporate that in our larger understanding of what's happening, we adjust our treatment plan, and we go from there. There is a little bit of trial and error to find the best course for each person. So I kind of spoke about this, so I won't go into it too much, but in general, with pain, we want to identify the problem. Like, what is the core issue? Why is it happening? How did it come to happen? What can we do to actually treat that long term? So most approaches for pain involve injection of steroid because steroids make people feel better generally. For hypermobility, for sprains of joints, steroids usually don't help so much, and they soften connective tissue, which makes things more stretchy, and they certainly don't provide any long-term solution. On the other hand, if there's an autoimmune condition coexisting with the hypermobile condition, we may want to prove that by giving a steroid injection. And the way we'll find out is we put a small amount of steroid in the joint. If they respond, if they feel amazing, there may be something more autoimmune going on, and that's when we'll work with the rheumatologist to tease that apart. Otherwise, regenerative medicine is generally the approach for hypermobility syndromes. Sometimes we don't start with the steroid because we don't suspect an autoimmune condition, and we start with regenerative medicine, and that can flare. And if someone flares with the regenerative medicine approach, that again makes me suspicious. Is there some autoimmune inflammatory process in play, or maybe there's some mast cell in play, because that can also react to it. So like I said, everything we do, it gives us a greater understanding of what's happening with the patient. We take that, we incorporate it into the bigger picture, and we work together. It's always a process. So again, if the core issue is laxity, we want to strengthen the ligaments and the supporting structures to improve stability. If the laxity is not treated, no amount of muscle coordination and strengthening is going to compensate for that laxity, because the core issue of the laxity will catch the patient when they're not guarding, when they're sleeping, when something else is happening. Or if they're using muscles to compensate for the laxity, they'll end up overusing those muscles, and then they'll come in with pain, disuse, tendinopathy of those muscles that are being overused. So looking at laxity and how we can treat that is the main goal of procedures for hypermobility spectrum disorders. And again, diagnosing pain versus hypermobility, I spoke about that a little bit. We want to understand both. Just going over the role of interventional physiatry, which is what I do. We are the specialists in biomechanics. We're the ones who really sort of put muscle, tendon, ligament, bone, joint, nerve function all together. We generally do diagnostic ultrasound, so we can use an ultrasound in the office to look at what's happening. We can often see hypermobility in real time. I can diagnose hernias in real time. A lot of hypermobility associated conditions can be diagnosed with ultrasound. We can also guide on when bracing is appropriate. There's mixed thoughts about bracing, because when you brace something, you don't use your own muscles to guard that structure, and those muscles can get weak. But there is a role for bracing, both diagnostically and therapeutically, and to prevent further injury. We can help with that. We're also the specialist in brain injury and spinal cord injury. So if there is craniocervical instability, tethered cord, autonomic dysfunction, CSF outflow, these are things we're all familiar with treating. And we also work closely with neuropsychologists, social workers, physical therapists, vocational rehab, all of the multidisciplinary team that's typically required to care for someone with more significant hypermobility spectrum disorders. And then, of course, we also do all of the procedures we talked about.